Hello, and welcome to episode 4 of the Ask the Expert podcast, a podcast series featuring interviews with experts from the bleeding disorders community on the topics that matter most. I'm your host, Patrick James Lynch. On May 4th, 2017, the United States House of Representatives voted to pass the American Health Care Act and thereby repeal most of the Affordable Care Act by a narrow margin of 217 votes to 213. This happened despite the bill polling horrifically with the public and with even Republican President Donald Trump referring to his own party's bill as, quote, mean. The passage in the House sent the bill to the Senate for deliberation. Senate Republicans approached the AHCA with an unprecedented level of secrecy. A group of 13 Republican senators, all men, drafted the Senate's bill, now titled Better Care Reconciliation Act, in private. The lack of transparency, coupled with Senate Majority Leader Mitch McConnell stating that he'd like a vote on the bill before the July 4th recess, raised serious bipartisan concerns about both the substance of the bill and the unprecedented nature of the process. Then on Thursday, June 22nd, Senate Republicans revealed the draft for the Better Care Reconciliation Act, and in short, it looks a whole lot like the House bill. And in some ways, it's even worse. So today, I've invited Katie Verb on Ask the Expert. Katie is the Director of Policy and Government Affairs with the Hemophilia Federation of America, where she's worked for the past 4 years. We talk about the unusual process by which this bill has come to life, compare it to how the Affordable Care Act, or Obamacare, came to life, what we've learned about this bill's contents thus far, and what advocacy efforts we as bleeding disorders community members should be focusing on between now and the time of a vote on this bill. That's coming up right now in my Ask the Expert interview of HFA's Katie Verb. Katie, hi, how are you?
I'm great. How are you?
I am doing well. Thank you for joining me for this. I'm sure this is a particularly busy time for you.
Yes.
Can you actually, before we're here obviously to talk about the healthcare bill, and I should say right at the top, we are recording this Monday, June 26th at just after 4 p.m. Eastern. So anything that changes after this moment, we didn't know that at the time. So you'll have to forgive us if we're missing any big information. Katie, can you just give us a little background on yourself when it comes to policy and legislation, healthcare, and then also explain to us what exactly it is that you do at HFA?
Absolutely. So as you said, I'm the Director of Policy and Government Relations, and I've been working in health policy. This is my 4th year with HFA, and prior to that, I did government relations for the Toy Industry Association. So my background is in doing that type of work in different policy areas. Came to HFA 4 years ago and dove right into health policy, and very happy to be here. I have a personal connection to the community. I have a few cousins that are affected, so it was a very serendipitous lineup, and I'm happy to be working for the community.
What have been, in your estimation, what have been some of the kind of major steps forward that you've seen the community take since you first started getting involved, 4 years ago, you said?
Yes, but it was 4 years ago. So I came on board right after the Affordable Care Act, and I would say that the ACA was probably the biggest leap forward that for the community. Obviously, disallowing insurance companies to discriminate against people with preexisting conditions, the annual and lifetime caps ban have been really the two largest pieces that affected the community, and then also our many members really benefited from Medicaid expansion. So I came on right after that and have just been working on other, I think, smaller issues, mostly in states since then. Working on a lot of state legislation surrounding caps on specialty tiers, and then working on state and actual federal legislation eliminating some step therapy policies in insurance plans.
And how much has that kind of what I'll call day-to-day work been impacted by this larger healthcare bill that has everyone's kind of attention wrapped? I imagine in some ways it's made some of that other, again, what I'm calling day-to-day advocacy and legal work more challenging. Is that accurate?
Yes, I would say that it's brought a lot to a screeching halt in January. Right after the election, we knew that we were going to have to gear up for a big fight this year, and we did, starting really in the beginning of January. I think the biggest thing was that we were just so concerned we didn't know what we were going to see. We didn't know how far the reform efforts were going to go, and that's been the sole focus it's just taken so much time and energy and effort trying to understand what these reforms mean and how they will impact the bleeding disorders community.
And ultimately, we want to get into what currently is in the substance of the drafted bill and what does it mean for our community and what should we be doing about that. But before we get there, let's just go back to the bill that is being considered right now. It's kind of been around in one iteration or another now for a little while. Can you just take us through the process? It's almost like that old Schoolhouse Rock episode, right? How a bill becomes law. Help us understand how we got to the stage that we are currently at.
So the bill is started in the House as the American Health Care Act. The House of Representatives worked on putting together a piece of legislation that we were very much opposed to, and they eventually, once the House passed it, they sent it over to the Senate. And there we were a little bit we'd heard a lot of different things. We've heard that the Senate was going to completely just start from scratch. We heard that they were not going to take this American Health Care Act and work on this. But a lot of the provisions in the Senate bill look a lot like the provisions in the House bill. But one thing that's a little bit different with this process is that the Senate bill is being passed through a process called reconciliation, and this allows Congress to expedite the process of passing bills that have certain tax, spending, and debt legislation. So these types of bills have to affect federal spending or revenue. They generally cannot increase the federal deficit, and they cannot change Social Security. But if the bill follows those rules, then it can be passed with a 50-vote margin instead of the normal 60 votes that would allow for a bill to pass in the Senate. So there was a House bill that really outlined, I would say the bill outlined the principles that the House wanted to see in health care reform. And then the Senate has put together their version, the Better Care Reconciliation Act, that has to follow those particular reconciliation rules and then can pass with, they say, a 50-vote margin because they believe that any tiebreaker will be broken by Vice President Pence. And so they need 50 votes plus him being one in a tiebreaker. What's been different about this is that the Affordable Care Act was put together over the course of about 5 years. They health economists, insurance companies, pharmaceutical companies, patient groups, the White House, so many different doctors groups were all involved in the process of putting together the Affordable Care Act. They sat down, things were reviewed, they were debated, they were put in town hall. President Obama went to various Republican groups and debated the merits of the bill over and over again with them. And then it was eventually passed as a general piece of legislation, not a reconciliation bill, but as a general piece of legislation through both the House and Senate with a bipartisan vote. So that came together in a much different way than this came together. This bill really came together with the House putting together their principles, the Senate trying to figure out how they can take some of those principles and put it through this reconciliation process so it moves much faster and needs much fewer votes, and then do the reform that way. It's also been done with no hearings, no committee meetings. That's also very unusual. Not a lot of stakeholder input. Even the stakeholder input that they say is happening, you don't really know. It's all happening behind closed doors. It's been very interesting to watch how they've really managed to throw this whole thing together.
Just to even go a little further on the comparison between the Obamacare process and the BCRA process, Obamacare had 25 consecutive days of hearings, which I saw somewhere was cited as the second longest in Senate history. Over 100 committee hearings, roundtables, walkthroughs, over 160 hours of debate, with 300 amendments in the end, including over 170 from the Republican Party. And currently we'll have had the text of the bill of the current BCRA for 1 week before the hopeful vote on Thursday. That's as opposed to 35 weeks with the ACA. So just to kind of draw that comparison out a little further. So the process has been very unusual. I think that point's been made quite clear. That's its own kind of problematic issue. But looking at the actual substance of the bill, and just before we started recording, you had asked if you could take a minute just because new information is continuing to come in. And again, by the time people are listening to this, things may have changed. But as it stands right now, can you highlight for us kind of the major watch-outs and red flags in the bill as currently composed?
Yes, the bill really is a kind of overall one of the major analysis points that a lot of healthcare policy people seem to be agreeing on at this point is that It's really a giant tax break in the form of health policy. The bill's main focus is on cutting all of these taxes in a number of different areas. And how that necessarily relates to health policy can be very frustrating. The biggest issue for us right now is that the bill very seriously undermines the protections for those with preexisting conditions. And it does this by allowing states to waive some of the basic coverage standards that were put in place under the Affordable Care Act. So the Affordable Care Act said that states or insurance plans that operate in states have to provide these essential health benefits, is what they were called. What was deemed basic health insurance coverage. Prior to the Affordable Care Act, health insurance coverage might have been cheaper for some people, but it covered so little. So even if you or someone who didn't need to utilize the healthcare system, so anything ever happened to you and you ever did, you would be paying, the coverage was so much less. So the Affordable Care Act really decided what are the elements that make coverage robust, that would keep somebody from economic ruin if they were to get an illness or if they were to have an accident. And this bill undermines a lot of those basic coverage standards. So even though insurance companies would still have to sell policies to all applicants, some technicalities varying, but they can exclude important benefits or treatments for certain conditions from coverage. So the pre-existing conditions, while it has been said in the media and said by all the people putting together this bill that they intend to protect people with pre-existing conditions, and we're not going to go back to that. Pre-existing condition protection is meaningless if insurance companies can just decline to cover expensive conditions or decline to cover certain parts of what taking care of that condition means. Certainly you can have a plan if you have a bleeding disorder, but we're never going to cover the cost factor, or we're never going to cover treatment, going to an HTC, or physical therapy is never going to be covered. So is that really a protection for you if we know that these are the things that our community will always need access to?
I just noticed while we're talking here, a minute or two ago, it must have come out that the Congressional Budget Office has determined that the current bill would knock 22 million people off insurance by 2026. So that's just 1 million lower than the House version, which was scored at 23 million. So not a huge step in the right direction if you are the Senate, anyone in the Senate who's thinking about trying to vote yes on this. You just mentioned all the great wins of Obamacare and how this threatens them. And in spite of any claims to protect those with pre-existing conditions, it seems quite clear to anyone who's doing the reading that the way this is being constructed, that is not a fair statement to make. How do you, and particularly someone like you who is in a position with HFA where it is neither productive nor professional for this conversation to become what it can become around a dinner table, which can become very politically heated. How do you navigate trying to communicate the urgency of people in our community getting involved and contacting their officials, their representatives, to make sure that they're being heard without the conversation turning in a direction that makes it a little bit more politically difficult to discuss? How do you navigate that on something as hot button as this?
Well, one of the things that we talk about, and you'll see in a lot of our messaging, is that no matter what your politics are, this is not the solution. Health policy is about outcomes. And policy, really true economic policy, health policy, things like this are about outcomes. And what do you want your outcome to be? If you want your outcome to be quality health care for people with rare and chronic disorders, how do you get there? And those things are, above and beyond red or blue, or they're above and beyond Democrat or Republican ideals. And it's above and beyond opinion in a lot of those situations. These tweaks, these changes are not how you get to that outcome. And so as a community, it doesn't matter if all of the other things that you may believe in that are about opinions, if the outcome that we all believe in as a community is that people with rare and chronic disorders, people with bleeding disorders need quality coverage, need quality access, how do you get there? And that's what this is about. And so we really try to stress that this whole healthcare policy debate has become so political over the past couple of years. Before it was called Obamacare, before it was called this wasn't a political debate. But now it makes it so much more difficult to really get to these outcomes because it's become so political. And, if you really think about this from a policy perspective and you think about this as a problem that you're trying to solve and take away those red or blue ideals, there can be a compromise. There can be ideas that are agreed upon. And that's the thing that's really frustrating about this bill is that it really feels like this bill is such a reaction to the Affordable Care Act as opposed to looking at the set of outcomes that you want for a society and then trying to figure out the economics of getting to those outcomes.
What does this bill suggest to you? What do you think the suggested desired outcome is? I like that way of framing kind of how we think about it. So if we look at this bill, what do you take away from it? What do you think the outcome is intended to be?
I think the outcome is intended to be a tax break. The tax break that the richest 400 people in the United States will get from this bill is equal to how much Nevada, West Virginia, Arkansas, and Arizona spend on Medicaid expansion. Whether that's something you believe in or not, that's what this bill is doing. This bill is giving huge tax cuts and huge tax breaks to large corporations, to incredibly, incredibly wealthy people, and they're doing that at the expense of health care coverage for not just low-income people in general. That feels, just from a policy standpoint, looking at that was really the outcome of this bill. From a policy standpoint, especially a health policy standpoint, it's very frustrating.
We've seen the emails from HFA and from NHF and from member organizations and chapters around the country encouraging activism and calling senators and congresspeople previously for the last couple of months. I'm curious to know, do you have any stories, or I think sometimes, I know I at least wonder, how effective are we being when we do these kinds of things? And obviously we have to do them. It's really part of the only power we have is to put the right kind of pressure on our representatives. But it can sometimes feel like shouting into the void or the abyss. Or maybe you live where I live in Los Angeles, California, where my congressman is Adam Schiff and my senators are Kamala Harris and Dianne Feinstein. I mean, I'm pretty aligned with where they're at, so I sometimes feel a little helpless. Do you have stories from community members who have had positive outcomes with advocacy efforts this year that you might be able to share?
Absolutely. We actually had a family from Ohio who came to our patient fly-in who talked to their representative about a federal step therapy bill, so not even in health reform. And that congressman ended up coming to our congressional reception, speaking with the family at length about how this practice would affect them, and made a great relationship with their office just coming here and doing that. And then a week after they got home, they got a letter saying that they were going to have to go through step therapy. And we ended up calling the congressman's office, letting them know they were able to intervene. They were also able to use their story to support their own efforts on the Hill. And this was a Republican member of Congress. So it was a great example of, again, this is not about Republicans or Democrats. Many of the bills that we support that have to do with step therapy or specialty tier legislation have been introduced by Republicans. So that was a really great win, being able to get a family to connect with their representative, have them came to our congressional reception, met a bunch of other members of the bleeding disorder community, he's a physician, but wasn't really well versed in what our community was like. And then afterwards, when they had a problem, we were able to contact their office and intervene and hopefully work to get that problem solved. So that was a great win. There's also a great story that Vox recently published about a woman specifically with hemophilia who was able to get their congressman on their side by simply calling them over and over and over again. He was I think a representative from North Dakota, and this was during the Affordable Care Act time, and this woman basically called his office every single day and talked to them about lifetime caps and convinced him eventually to vote in favor of the Affordable Care Act because of that issue specifically. So I think that it is really helpful, and I believe it is vital to keep up doing that, and to keep. We're maybe small in number, but I know that when I'm on the Hill, I almost never have to explain what a bleeding disorder is anymore. Our presence there is so wide through all the groups that go that it makes my job a lot easier, and just that continuing effort to say yes. Well, and a lot of the members' offices here know people specifically, know families specifically who are involved. And it just makes our presence and our ability to affect change in our relationships is that much more deeper and more important.
So I guess this goes without saying, but it is certainly in the best interest of all of us for people to continue making those phone calls or writing letters or sending emails to their representatives to voice what I would hope to be their ardent opposition to this proposed bill, yeah?
Yes, absolutely.
So we've heard for a while that the July 4th deadline has been a goal from the 13-member committee who is drafting the bill and by the Senate Majority Leader McConnell. Many believe that that's the goal because they don't want to necessarily, those who are crafting the bill and putting it together, don't want to have to then go home and face constituents during recess. We saw how those town halls went during the bill's consideration in the House, and there was a lot of bad press for the bill, to say the least. Now, if that mark is not hit, it is not necessarily condemning the bill if they don't get the vote done before that recess. But there is a little bit of a time crunch on how long this bill has life for. If it's not done, I think, by the time the August recess comes up, procedurally speaking, they have to start from square one. I'm not completely clear on how the process works. Is that something that you might be able to shine a little bit of light on?
Yes, they're supposed to before. And the issue is that before they can move on to anything else and dealing with any other tax issues, that they will have to get this done first. And I don't believe that they want to do that. So I believe that they will put this up for a vote as soon as humanly possible. Before the rest of the budget is done, and that's usually done in the fall, and before tax bills are pushed through, which is usually done in the fall, they would need to get this reconciliation bill done.
And as it stands right now, as you mentioned earlier, because it is a reconciliation bill, there are only 51 yes votes needed as opposed to 60, and with Vice President Pence as the tiebreaker, the goal in the Senate for a yes is 50, which means that the Republican Party can only afford to lose, so to speak, 2 senators before they will not have the votes to pass this bill. Thus far, no Democrat or anyone who caucuses with the Democrats has even suggested that they would consider supporting this bill. And it sounds like today we have 4 or 5 senators already who have voiced that they are not pleased with the bill as is, which is always kind of alarming language, suggesting that they, or as one senator said, they want to get to a yes. So we can't take too much comfort from hearing about 4 or 5 presumed no's. But based on where you sit, how do you see the next week or so shaking out? Do you think we get to a vote by Thursday? Do you think the votes will be there, or do you see it going differently?
Well, I believe that some of the people that have said that they are against it, it's a little bit more posturing than it is actual. I think that they would not have brought this up for a vote if they didn't have them. If they didn't believe that they had the possibility to get to this number of votes, that I think that's where you would have seen the process stop, is that the bill wouldn't have been introduced as it is now. I will say, though, that there are a couple of people, we've got some target states that we are hoping can be swayed, and right now that list is Arizona, Louisiana, Nevada, West Virginia, Maine are our top 4. So if anyone listening lives in those states and would like to, call their senators and apply pressure, but I think unfortunately that they are farther along getting votes than the press might be reporting, given that they led to this introduction and given that a failure here would be so devastating for the party and devastating for the effort.
And just a little more background, those 4 states, some senators are either in a particularly purple state, so to speak, such as Nevada, and or are up for re-election in 2018, and or are a state that greatly benefited from the Medicaid expansions under Obamacare, like West Virginia. I think more than any other state, West Virginia benefited. So those are all. Yeah. That's, I think, why those states are. You hear them come up again and again in terms of strategic activism, and that's the reasoning for that. And if the votes aren't there, well, actually, let's go the other way first. Let's play out the tape that the votes are there, but this passes, goes back to the House, and with some amount of nominal amendments, a version of what we're looking at now passes. What does that mean for the bleeding disorders community?
Well, it would, I believe, put a lot of people's coverage at risk. I think that we will see, especially for people with rare and chronic disorders, we will see premiums go up. Right now, the amendment that was introduced this morning to BCRA has to do with trying to get healthy people to buy insurance. That's really been kind of one of the cruxes of the issues with legislating and issues with health reform from the start. How do we get healthy people to buy insurance and balance out, the sick people that need insurance? And the individual mandate was supposed to do that, but it was so, obviously the biggest issue that everyone disagreed with in the country. So in order to replace that, they put in this morning a provision that will lock out people from purchasing insurance for 6 months if they had not and suddenly need to. So instead of mandating that an individual buys insurance, this provision will lock people out who did not. But the problem with that is that the concern is that the lockout period will make the risk pool sicker. So it will still keep only sick people in. People with health conditions like bleeding disorders often have insurance. They've always had insurance. So this period, it really doesn't provide any additional incentive for healthy people who weren't inclined to buy insurance in the first place, whereas the mandate and that actual, that penalty would have, simply saying that, well, fine, you can't. The other biggest concern is that what happens when those people need insurance? So let's say you've been somebody who doesn't want to buy insurance, you're healthy, you think, I don't need that, you're not contributing. There's no punishment for you to do that now. There's no fee you've got to pay. There's no mandate. And then you all of a sudden get sick. But now you can't buy insurance for 6 months. Who pays that bill then? Are you going to the ER? And are you going to be on state Medicaid? That's a really big question that the bill does not answer. There is nothing in it that is going to help stabilize the market by adding healthy people to the risk pool, and then while alternatively providing for no kind of recourse for anything happening to healthy people, or no understanding of who pays that bill then all of a sudden.
And if we see this not go through, if the votes aren't there, and this in one way or another eventually dies on the vine, so to speak, should we expect to see another attempt at creating a replacement for Obamacare or major amendments to it? What should we expect to see if this does not pass?
I think what we will see if this does not pass is the focus shift to tax reform for a while, and then efforts starting back again in just more of a general reform, not through the budget reconciliation process in the fall. I don't think that this is going to be let go, or this effort is going to be let go. But I think that after this, as we were talking about earlier, that the focus is going to have to shift, and they're going to have to work on tax reform and then come back to this in the fall.
I had mentioned to some community members that we were going to be chatting today, and got a couple of questions. If you have a few more minutes, I'll just maybe ask you two of these questions that came in from community members.
Sure.
Our first question is, will it be possible to reintroduce lifetime caps because of the per capita cap system, and under what circumstances could someone with a pre-existing condition be denied coverage? We kind of already talked about this, but maybe a little more specifically, how exactly could someone with a pre-existing be denied coverage if the bill goes through as presently composed?
So the per capita cap system applies to Medicaid. The changes for per capita caps that they want to make are in the Medicaid system. And that, for our community, it's estimated that about 30% of the population with bleeding disorders relies on Medicaid. So any cuts to that system, you will see cuts to health care and state Medicaid programs across the board. Caps are particularly disturbing because they're very disproportionate and inequitable. The caps that are being proposed, they lock in historic spending patterns. So if a state, spends $1 million, that's obviously these are not the numbers. Let's say they spend $1 billion on healthcare this year, then that's it. When these caps are locked in place, they're locked in there, and then the growth rate is tied to the consumer price index. But the Medicaid has actually grown historically faster than that, so the caps will lock in spending at a certain rate and then tie it to an index that does not grow as fast as spending on Medicaid does. So that will never be able to catch up if there are any changes in the healthcare system, in that state's healthcare system. So maybe the changes are good and the state has implemented a incentive program that's led to better health outcomes, and they want to reinvest those funds in other areas. They can't do that even. It doesn't compensate for any increased need in traditionally low-income states. It doesn't compensate for any of the states that have already come to rely on the Medicaid expansion. So that's how the per capita caps will affect states, is that they will lock them in and they will never be able to change how they are spending on Medicaid. And then they will have to make really difficult decisions about where they spend money. We've got a lot of people that utilize the Medicaid program, and right now we've been able to keep payments for their product and keep payments for their hemophilia treatment centers because we've been able to say, this is the best way, this is the standard of care for the community. But if the states can no longer afford to make those payments, they're going to have to figure out a different way to spend that money. And so that's really concerning for our community. Those, however, the per capita caps will affect us. It's the annual and lifetime caps. Those are different. Those are for a private insurance market. And what this does is if right now the annual and lifetime caps are tied to spending on essential health benefits. So if there are the 10 essential health benefits, then anything that an insurance company spends on those things, that all there's no cap on that. So you won't, even if you need physical therapy every single day, and that's part of the essential health benefits, there's not going to be a limit or to an annual or lifetime limit to how much your insurance company has to spend on that. But if certain states don't cover all of those benefits, or if certain plans don't cover all of those benefits, then they can say, okay, well, you know what, we are going to pay for physical therapy, but we're only going to pay for $1 million for physical therapy over your lifetime. And they can make decisions about conditions then. They can make decisions about certain treatment protocols. I mean, if they don't have to cover everything, they can say, oh, you know what, we're only going to cover these 3 or 4 things. And, okay, you can spend as much as you want on that, and there's no annual or lifetime cap, but these other things aren't included in that. So that's where the annual and lifetime caps come in, is that there is no longer a protection in this bill that insurance companies have to provide certain services, and those services are exempt from any type of annual or lifetime limit spending. And that's the thing that it erodes that coverage. So again, you might have coverage, you might have a plan, but if a person with a bleeding disorder purchases a plan that only covers, 2 visits to a doctor and no specialty medication and no physical therapy, is that really coverage? That's our biggest concern.
Yeah, it kind of reminds me of what you were saying earlier about before the ACA, the quality of the coverage was much lower than it became with the ACA. So it kind of seems in a way like it would be stepping back into that type of a landscape, or in a healthcare landscape at least. One last question. This one mother mentions that she has 9 pre-existing conditions in her family. And she's wondering, would all of those count against the family as a whole when picking a plan, or would they just use one as grounds for a denial? I'm not sure how much that kind of number 9 versus 1 comes into it, but what is your response to that? It's kind of an interesting question.
That is interesting. We don't actually have to worry about that as much, that kind of list of diseases under the Senate bill as we did under the House bill. The House bill did have very limited protections with pre-existing conditions and that sort of list of pre-existing conditions. That list was very broad. I mean, your ability to become pregnant as a woman, I think, was on that list as a pre-existing condition. But I would say that the one fortunate thing is that we don't have to worry about that kind of listing of pre-existing conditions, and that, again, it's insurance companies do have to sell policies to people with pre-existing conditions. There's just no telling how much those policies cost and what they have to cover.
Well, Katie, we've covered a lot of ground here. I think probably the takeaway message is for people to continue to make those phone calls, 202-224-3121 to reach the circuit, or not the switchboard. That's what I was looking for, the Senate switchboard, 202-224-3121. And in particular, as Katie mentioned, if you or family or friends live in West Virginia, Nevada, Maine, and what was the fourth target state? Louisiana. Those are voices that are particularly needed right now. So please encourage friends and family in those areas to also be making their calls to their senators to vote no on this healthcare bill. Katie, not our most pleasant topic to have to discuss, but again, thank you for coming on and helping educate and empower us to do what we can to be the best advocates we can for the best healthcare we can fight for.
Absolutely. Thanks so much for having me.
Thank you again to Katie for taking the time to come on the pod today. I thought it was a useful conversation. I hope you, listeners, agree. I hope you learned something, and I hope it helps you keep motivated to keep up the advocacy efforts. It's important, especially if you live in Maine, Louisiana, Nevada, or West Virginia. And that is all for episode 4 of the Ask the Expert podcast. We'll be back next month with another expert interview on another topic that matters to you. Don't forget to subscribe to the Ask the Expert podcast, the Powering Through podcast, and the Bloodline podcast on iTunes, Stitcher, or wherever you listen to podcasts, or visit bloodstreammedia.com to stream or subscribe all of Bloodstream Media's podcasts for the bleeding disorders community. Have an idea for a future episode of Ask the Expert? Email us at mailbag@bloodstreammedia.com. You'll also find Bloodstream on facebook.com/bloodstreammedia and on Twitter @bloodstreaminfo. This episode of Bloodstream was written by Patrick James Lynch, produced by Patrick James Lynch, Rob Bradford, Andrew Gall, Josh Bragg, Alva Friedman, and Colby Crow, and edited by Josh Davis. I'm your host, Patrick James Lynch, and until next time, take self-care of yourself.